Good evening. Welcome you all to our regular Zoom-based activities of the Gynaecological Oncology, which is organized by the Oncology Club. Today, our topics is usually in last 2 years during the COVID era, we are arranging this program in weekly, but in from this March, we are trying to organize this in fortnightly. And accordingly, this program was in last Sunday, but our faculty, today's faculty, she has another commitment, so she could not attend in last Sunday, and we have to shift the program to this Sunday. And the program is on the imaging in gynecological oncology, the current practice and the recommendation. As you know, the imaging is the very important in nowadays in managing the gynecological cancer. So we have to choose the topics, and this year we have trying to choose the topics in different way like this. Our faculty today is overseas faculties, Dr. Palok Vivash Popal. She is Associate Professor, Radio Diagnosis, and she has specialized in the women's onco-imaging. She is working in Tata Memorial Hospital, Mumbai. Our faculty today, our local presenter is Dr. Sushmita Bardhan. She is fellow in gynecological oncology and working in National Institute of Cancer Research and Hospital, Dhaka. The teachers and the shade who are with us always in our program, our scientific secretary, Dr. A.F.M. Kamaluddin, Professor Dr. A.M. Shariful Alam, sir is the General Secretary of the Oncology Club, and our inspirator always is Professor Dr. M.A. Haisar, sir is the President of the Oncology Club. Thank you. Now I request at first the chairpersons of the today's session, Professor Dr. M.A. Haisar, to give us to say something and give us permission to start the session. Sir, please.
Bismillahirrahmanirrahim. Thank you, Dr. Shan. I'm very happy that you have started this in the month of Ramadan, also continuing the program. Today's our faculty is Dr. Palak Bhavesh Papat from Bombay. Thank you very much, Dr. Papat, for joining us. We are very much grateful to you. We're very much grateful to you. Now, today's presenter, Dr. Sushmita Bardhan. I think without any delay, we already have 20 minutes left. So we should start immediately. Shana, start immediately without any delay.
Thank you, sir. Now I request the Sushmita Bardhan. Sushmita Bardhan, please start your presentation, Sushmita.
Thank you, madam. Am I audible, madam?
Yes, I have to do the slideshow to that.
Is it visible?
Yes, visible. Slideshow to them. Slideshow.
The slideshow to that.
Okay. So, chole gেছে তো screen share.
Is it okay, madam?
No, ওই নিচে যেটা ওই কাপের মতো দেখা যায় নিচে
স্লাইডশো আমার এখানে আসছে
আমরা তো দেখতে পাচ্ছি আবার চলে গেছে yes it's okay now.
Honorable Chairperson, respected foreign faculties, my teachers, my colleagues and learned audience. Salam, Namaskar, and very good evening, and welcome you all to my today's presentation, Imaging in Gynecological Oncology, Current Practice and Recommendations. Slide move corner. The common imaging modalities that are used in gynecological malignancies are ultrasound, computed tomography, magnetic resonance imaging, positron emission tomography. The ultrasound is a very popular and primary imaging modality. It has some advantages over the advanced imaging. That ultrasonogram is commonly available, inexpensive, non-invasive, and less discomfort. CT scan is used from 1970s for staging of the pelvic cancers. Pelvic and abdominal CT scan allows an evaluation of the liver, omentum, urinary tract, bony structures, and lymph nodes, and can detect lymph nodes more than 1 centimeter diameter. But CT scan cannot differentiate inflammatory or hyperplastic enlargement from metastasis. MRI has high contrast resolution and multiplanar imaging capability. Due to better soft tissue resolution, more accurately it can detect tumor size, parametrial or myometrial invasion than CT scan, and give idea about the local resectability of the tumor. Similar accuracy like CT scan to detect the lymph node metastasis. PET uses radionucleotides decay with the site metastasis that are undetectable by conventional imaging studies. Now, imaging used in cervical cancer. Imaging has a very important among all the techniques, MRI plays extension. Now see what the guideline says about the principle of imaging in cervical cancer. And but they also option for treatment planning before chemoradiotherapy with curative intent. This is the tumor, but there are also some iso-intent, hypo-intent sarcoma. So this is the stage 1B1, stage 1B. And in this sagittal section, there is hyperintense tumor, and there is also involvement of the upper 1/3 of the vagina. So it is stage 2A. This is the and you can see the parametrial right parametrial invasion here. This is the certain advanced disease. The tumor is invade into the rectum. This is the axial view of the CT scan of the pelvis. Here we can see the pelvic lymph node, and this is the coronal view. We can see the cervical cancer infiltrated into the endometrium, myometrium, and here the paracervix also. This is the axial. Just a minute,
Sadia Nusrat, please mute. It's the important program. Please, Sadia Nusrat. Sorry,
This is the axial view of the upper abdomen CT scan. Here we can see that there is liver mets here. This is a very popular picture from Berek. It is a PET scan of cervix and cervical cancer. Here the primary cervical cancer with uterine invasion, and here this is the paraortic nodes. This is the axial view, and there is a recurrent lesion over the right presacral area. Imaging also help in the treatment of cervical cancer when planning done for radiotherapy, and image-guided brachytherapy also. Now, imaging during follow-up. What are the guidelines? Imaging should be based on symptomatology and clinical concern for recurrent or metastatic disease. And for patient with Figo stage 1B3 or the patients who require postoperative adjuvant radiation due to high risk factors, neck, chest, abdomen, pelvis, groin, PET CT may be performed at 3 to 6 months after completion of the treatment. And stage 2 to 4 who received chemoradiation, neck or chest, abdomen, pelvis, groin, PET CT preferred, or chest, abdomen, pelvic CT with contrast within 3 to 6 months of completion of therapy. Consider pelvic MRI with contrast at 3 to 6 months post completion of therapy. ESGO guideline that imaging and laboratory tests for morbidity during follow-up not higher than 3 months. Weeks thereafter. And they also said that symptomatic women MRI or CT should be considered to clinical whom surgery or radiotherapy is being considered. Is our patient poor? What can we do? Is there any alternative to MRI in some countries by Olpin J and et al. And they review and this review discusses the role of ultrasound and CT in the planning of management of the cervical cancer in low middle income countries, and how the optimization of the treatment with surgery or CCRT may be enhanced with this imaging technology. Here, transrectal ultrasound and may be an option. This is a paper published in International Gynaecological Cancer Journal in 2008 and 2018. Transrectal ultrasound and magnetic resonance imaging in staging of early cervical cancer by Fischirova et al. And they said that they find that ultrasound has higher accuracy than MRI in tumor identification of the residual tumor after previous biopsy, and also measurement of the tumor size and also the parametrial spread. This is another paper. And they also said, this is published in 2009, transvaginal sonography and MRI for assessment of the presence, size and extent of the invasive cervical cancer. Here, the 75 patients with early stage disease included, and ultrasound detected the presence of tumor, deep stromal invasion, infiltrated parametrium with an accuracy at least similar to or greater than MRI. This is another paper. Here, early stage cervical cancer tumor delineation by MRI ultrasound. This is an European multicenter trial, and the time period was 2007 to 2010 and published in 2013. And they here 182 patients are included with early cervical cancer. They said that better detection of residual tumor and parametrial invasion than MRI, and comparable accuracy both imaging in the size assessment and evaluation of the deep stromal invasion. Now, this is some pictures of transrectal ultrasound in case in cervical cancer staging. This is the transrectal ultrasound. This in this picture, we can see that involvement of the right parametrium here. for the diagnosis of ovarian cancer. Rule for predict, that is M rules, rule for predicting a malignant tumor. There are some points: irregular solid tumor, presence of ascites, at least 4 papillary structures, irregular multilocular solid tumor with largest diameter more than 100 millimeter, and very strong blood flow, that is color score 4. And rules for predicting a benign tumor, B rules: unilocular, presence of solid components where the largest solid component has the largest diameter less than 7 millimeter, presence of acoustic shadows, smooth multilocular tumor with largest diameter less than 100 millimeter, and no blood flow, that is color score 1. When one or more M rule is present without B rule, that is prediction is malignant tumor, and one or more B rule without M rule, then the prediction is benign tumor. But when both present or both absent, the result is univocal. This is a ultrasonic image of a patient with endometrioma. Here it is a unilateral ground glass echogenicity seen here. This is an and this is a patient of unilocular anything here this is multilocular low level echo, but no solid or papillary structure, muscularity 2, and no shadow, no ascites, that is it is mucinous cyst adenoma. And this is the picture of stage 4 ovarian carcinoma. Here tumor is at least, it is a moderate blood flow ascites. Now imaging help preoperative prediction of resectability by imaging. Optimal cytoreduction is difficult to achieve in the presence of extensive disease on the diaphragm, extensive liver parenchymal disease, base of the small bowel mesentery, laseromentum, porta hepatis. Now, this is the schematic of the common site of the disease in ovarian cancer. How can we predict that it is resectable or non-resectable? Types of non-resectable. Diffuse mesenteric involvement, root of the small bowel mesentery involvement, and here in the pelvis, potentially resectable disease, hepatic portal Iliac falciform ligament, Morrison's pause, and gallbladder fossa, Morrison's pause. And rectal diffuse cerebral invasion and uteric invasion. When we see, we should evaluate the right upper quadrant like this, left upper quadrant, and pelvis for the disease. This is the hepatic ligament and porta hepatic disease. This porta hepatic disease. And in this, this is the pelvis side of involvement, non-resectable disease. This is the coronal coronal scan of the CT scan. Here we can see multiple peritoneal This is resectable metastatic peritoneal nodules here. This. The pelvic and here bilateral ureter and disease in the portohepatitis. And this is in the mesenchymal. The peritoneal implants CT scan can we can guess the resectability, but there are some limitations that this is the same patient's pictures. Limitation of CT in detecting small peritoneal implants. That is here we can see this is the small deposit miliary implants, but in CT scan it's not. It's like when announcing in endometrial carcinoma. This is positive is 18 cervical involvement, and TVS plays a very important role in primary diagnosis in essential thickness to 5 millimeter. This is normal endometrial and CT scan and image MRI of the endometrial carcinoma patients. This is the scan of scan MRI. In picture A, and the axial view, this is the myometrial, same patient, myometrial.
Sure. Thank you so much, Dr. Shavana. I do thank you and your team and Dr. Supriya Chopra for having me on board. It's a pleasure to be here. Is my screen visible?
Yes, ma'am.
Dr. Sushmita, I thank you. That was a fantastic presentation from your side, being a gynae-oncologist, and I don't think I have anything much more to teach after what you've enlightened everybody on. So let me just touch up through cervical, endometrial, and ovarian cancers. So the guidelines have been covered. I will not be dwelling in detail for those. So looking at carcinoma cervix. So what do we want to know when we are going to image a patient of carcinoma cervix? We would want to know the anatomy radiologically, the staging, the response assessment and recurrences, role of various modalities that we have, and we need to have an ideal reporting checklist, which you and I, both of us, are going to understand. So the first thing comes is a planning. So when we look at an ultrasound, the limitation of ultrasound, it is really subjective. So I may see something, I might have missed something, my colleague could have picked up something which I did not see. And I may have captured some images, which when somebody reviews, they can only see what I have captured, and I may not capture everything. So that's when it becomes quite a subjective assessment. Ultrasound is a very good modality if done very diligently. A CT scan is a no-brainer. The patient just has to, it's a routine protocol in a matter of 5 minutes. You have the stand ready and there is nothing to learn on the protocol development. What comes into protocol planning is an MRI. So for MRI, it depends. It is a very good tool if imaging is done in the right way. If we don't plan the study well, then we have lost half the battle. So a good radiologist is when you have a good technologist who's going to give you good imaging. It is only then can I interpret something. So if the technologist is not good, nothing to worry. The radiologist or the gynaecologist needs to have a collaboration with the radiologist and to train their technologists to give us the images that we want for diagnosis. So for example, this is a sagittal section of the uterus, and this is a sagittal section again, but this is a parasagittal section and this is a sagittal section. So now if we look at the planes, so a direct axial plane is going to be horizontal, but that is not going to go along the axis of the uterus. So the first point of planning becomes that the planning lines need to be along the axis of the uterine body for endometrium or the cervix for the cervical lesions. So an oblique axial is going to go along the red lines that are shown over here. However, the oblique axial lines for the cervix are going to be in an opposite fashion. So if we intermix the two, the anatomy changes, the staging and the extent of disease is not going to be orthogonal. So this is the first thing to remember. And an oblique sagittal image will be perpendicular always, but an oblique coronal image again over here will be oblique along the long axis of the organ that we want to see. This is a dictum. So let us look at the anatomy of the normal uterus. So this is a sagittal section. We have the sacrum behind. We have the anterior abdominal wall and the pubic symphysis in the front. Behind that, we have a completely collapsed bladder. And behind that, we have the uterine body and the cervix, which is held in the chalice-like vaginal cup. This is the anterior vaginal wall, and this is the posterior vaginal wall, which is longer. All right. The uterine body is much more brighter, or we can say gray, because it has a little more of water component. So it is gray. However, we have an inner myometrium, which is a junctional zone. And this normally is darker because it is more compact compared to the outer myometrium. This thickness varies because more than 12 millimeters, we are worried about some other hypoplastic adenomyotic changes. Coming down, the inner myometrium continues down into the cervical lips. This is the anterior cervical lip. This is the posterior cervical lip. The cervix per se is a much more tougher and a more compact structure. So it is much more darker on an MRI compared to its uterine body. Within that, this is an endometrium which is collapsed. So this is the collapse or apposed endometrial surfaces. And we come down here, we have some minimal endocervical fluid here and the endocervical mucosal lining. And this is minimal fluid in the endovaginal cavity. Coming to an axial section over here, we have the dark compact cervical stroma of the cervical lips. And then we have a little gray structure over here, which is some part of the parametrial vessels and some inflammation perhaps. And this is a bright normal parametrial fat. The structure seen behind is the rectum and seen in the front is the bladder. This is dark because it is a wall of the bladder and not the urine in the bladder. And we have the bones on the side walls and we have the vessels. So coming to the coronal anatomy, as I go from posterior to anterior, so we see the bones, the sacroiliac joints are seen here, the sigmoid and the rectum is seen here, the levator anis. As I come anteriorly, we start seeing the uterus, and further anteriorly, we see the uterine body, and we see the endometrial canal, and this is the part of the cervix, and on the each side, we see the parametrium. So the uterine artery nicely, beautifully is delineated in the coronal plane, and that is going to be a landmark for the parametrium. This is a parametrial leash of vessels again, and further coming anteriorly, that was the end of it. Now, so there is a way to just, imaginary lines are there, which if we can have two horizontal lines across the anterior and the posterior lip of the cervix. And then two imaginary lines are dropped along the direction of the uterosacral ligaments. And these would define your boundaries for the lateral and the anterior posterior parametriums. Right in front, this would be the bladder. So we have the anterior vesical space, and this is the rectum. We have the rectal space posteriorly. So this is a reflection of what we see on imaging compared to your surgical inputs. So this is a uterus, and we have the broad ligament stretched out here. We have the round ligament going anteriorly, and this is the posterior ligament, and that would be the cardinal space. That was the line of the ureter. The ureter goes with the peritoneum where it is reflected, the external iliac vessels and the internal iliac vessels, and I'll show you these on imaging also. This is an opened out, spaced out spaces. So all these are dead spaces in the body, but we see them very well on imaging as structures. So this is the paravesical space that we see on the MR. Again, I will show you the paravesical space. This is the parametrial space in the harboring the broad ligament, and we have the pararectal space which was seen posteriorly. Again, if this is the uterus, the space behind the uterus is the rectovaginal space, which I showed you, and the anterior space was the vesico-cervical space. Okay, so we have the bladder, cervix posterior, anterior posterior, we have the spaces and lateral parametrial spaces and the anterior and posterior parametrial spaces. Obturator fossa, so I know how much you all have to dig in to reach to that obturator space, but we see a node very well, and hence it is important for us to identify and nomenclature, use appropriate nomenclature for the nodes, which eases out your preoperative expectation of the surgical procedure. So as I said, this is where we have the cervix. This will be the parametrium, the anterior space, the vesical space, rectal space, and the lateral parametrium. So coming to the regional lymph nodes, we have a certain nomenclature. These are the external iliac vessels. So the nodes harboring along them would be the lateral, middle, and the medial. The medial, as we go above or superiorly, this medial node gets positioned very close to the nodes over here along the obturator nodes. So these would be the level of the obturator arteries, which are definitely called as an obturator node. However, in a higher section, we have a common nomenclature. They may be called as the medial external iliac node or an obturator node. This is an example of internal iliac nodes. These are the internal iliac vessels. And then we have the anterior and the lateral presacral nodes. The normal node would be something like this. This is a normal node. We have a very nice thin cortical outline. See, the fat is suppressed. This is a post-contrast fat suppressed image. So we are not worried about this node at all. We would call this definitely reactive. So it helps, imaging helps when we say definitely reactive, or it is definitely metastatic. But in the intermediate groups, yes, we always struggle on as to what should be the designation of that node. So coming to protocol, it's good to keep the patient fasting for 4 to 6 hours. An antiperistaltic agent may or may not be given. Bladder has to be emptied, because otherwise what happens in a cold air-conditioned room, the patient starts moving on the table while an MRI is being done, and then that causes it hampers the imaging quality. A consent needs to be taken. Multi-channel coils are used for vaginal jelly. So this is very important to introduce while performing an MRI of the cervix or of the lower endometrial cavity. And I will show you some image how it helps us. There are specific sequences that we use. So we have a small field of view, T2 weighted image, sagittal, oblique axial, oblique coronal. We have axial diffusion and ADC maps, a large FOV T1 for the abdomen and pelvis, and dynamic post-contrast imaging in small cancers or for post-therapy assessment. It is not needed for all cancers. So staging. So stage T1 is confined to the cervix. I will not go into those details. So let me show you the imaging. This white fluid that you see over here, this is the lignocaine jelly or the sterile jelly that we say must be instilled through the vaginal cavity. So here we have a sagittal section. The anteriorly is a pubic symphysis bone again and the anterior abdominal wall. Posteriorly, we have the sacrum and the sigmoid and the rectum. And this is the uterine body, and this is the posterior vaginal wall and the anterior vaginal wall. We have the posterior cervical lip, which is normal, but the anterior cervical lip stops here and there is this apple-like growth over here, exophytically growing from the anterior lip of the cervix. It is confined. The anterior vaginal wall is very nicely separated out. There is no vaginal wall or fornation involvement. And this is a very early disease, which can be definitely well treated. But this is the beauty of the lignocaine jelly, where because of, if we did not use lignocaine jelly, what happens? So we see the gray structure of the vaginal wall, the gray structure of the bladder, and the gray structure of the disease and the cervical lip. They all come together and they all look just the same. So what we need to do is we open up the space, and the fluid is white, whereas everything else is gray. So the moment it just delineates or outlines a tumor or the cervical lip, the diagnostic accuracy is so much better. This is an example of an endophytic tumor. So clinically, you all would feel that yes, there's an irregular growth and perhaps the para may be soft, but there are certain criteria for deciding on the management of the patient. This may also be seen on an ultrasound, but if, however, ultrasound characterization is not very good for some reason, then an MRI really scores over, where a definite endophycity and the extension of the tumor into the uterine segment can be seen very well. So there is no other imaging which is going to tell you, give you this answer. Clinically, we fail over here. And on a CT scan also, we fail over here, because the reason is everything is gray on a CT. So if we want to see an endophytic and ingrowth of a mass, we cannot appreciate it on a CT. So a good ultrasound definitely will help, and an MRI can be done for a more accurate disease requirement if it is needed. So then coming to this, another case over here. So we have this large polypoidal lesion in the sagittal section, see here, bladder anteriorly, rectum posteriorly, uterine body is uninvolved. So we see that there is a continuity along the anterior lip of the cervix, and there was not much vaginal jelly that could be instilled. So whatever little went in and then it just oozed out. But what we can see is that there is still a nice rim over here, and we can very beautifully see it all around. We can see it all around the tumor here. So we are sure that there is no vaginal wall involvement. And this is hematometra caused superiorly by an obstruction over here. This could be a benign, large endocervical polyp, or it could be a polypoidal malignancy. Histopathology would give us the answer, but MRI over here helps in staging and telling us that, okay, this is also an early stage disease and it is not involving adjoining structures. Now looking at tumors which are beyond the uterus. So here again, we have the uterine body here, the bladder and the sigmoid. This is the vagina, and in the vagina, we have vaginal fluid here. What would be felt by a per vaginal examination would be this margin, where again an irregular growth is felt, but we have an endophytic disease here. It is definitely involving the anterior cervical lip and the fornix. So as we see over here in the midsection, a significant hematometra, the bladder wall is completely uninvolved. There is no doubt in it. And definitely the upper vagina is involved over here, and the MR delineates it beautifully. This is a post contrast. So to remember that myometrium is much more intensely enhancing than the cervix, which is why cervical tumors are usually hypo-enhancing. So they are a bit darker compared to the myometrial enhancement. This is another sequence. So here, why are we seeing the bladder so bright? Because by the time this delayed post-contrast imaging is taken, a good amount of contrast has already come into the bladder, which is why we see a high intensity in the bladder. We have the cervical disease here and over here. So this helps in good staging, and this patient would perhaps appropriately go in for a radiotherapy. This is a benefit of a diffusion-weighted imaging where so fluid, normal fluid is suppressed on diffusion. So we are not going to be seeing it as a high signal, but tumor is very, very cellular. and there are too many cells. So what happens in diffusion sequence is that there are too many cells that are tightly packed. So imagine a very crowded train, and there is no space for a newcomer to just go in and maneuver around. So when this newcomer cannot go around, the movements are all restricted. Nobody can move. And that is what is called as restricted diffusion. So because the intercellular space movement is hampered, there is restriction of that movement, and which is why we say this is restricted diffusion. So that is based on the Brownian movement, which is similar to the intercellular movement space that I described. So when we say that there is restricted diffusion, it is going to be bright on the diffusion sequence. So if the urine is not seen, it is black. We are looking at a diffusion sequence. This always has to be seen with a ADC map. So in an ADC sequence, it is a reverse. So what is bright on diffusion should become dark on an ADC also. Why am I saying? Because if I see this and it is still white over here on the ADC, that means that this is an artifact because of a technical issue. So if I see a white restricted area on the diffusion becoming black on ADC, then it confirms that this is a very, very packed cellular area, which is going to represent a tumor. So this is an example of how there is so much of lucidity and fluidity, and over here we have a restricted diffusion. Another example where now this will be a stage 2A2, a large tumor, endophytic and exophytic, it is involving the vagina. So although the posterior vaginal wall is perhaps not that involved, anteriorly the vaginal wall is involved quite definitely a little more than the half of the vagina. And this is the posterior bladder wall. So if you see the delineation from this point onwards, I do not see the normal bladder wall signal intensity. And there is also some endoluminal growth, or there is bladder wall cystitis. But definitely this is involvement of the bladder wall is what you would think. Now let us look at the other sequence. This is example of a 2B. So here, so this patient, so I think I would over here, I would give this as a bladder wall involvement, but this example was cited here for its endophysity and the vaginal wall involvement. But if it definitely goes into the bladder, it would become a 4A. Looking at this tumor here, so there is parametrial infiltration over here on both sides. So this would be stage 2B. And there is no doubt that it is reaching quite close to the lateral pelvic wall. Now there is a certain discrepancy here in determining the extent of the lateral pelvic wall. So anatomically, when we say it is the bones and the vessels, by radiation, it would mean being about 4 millimeters medial to the wall of the vessel. But sometimes in obese patients, this fat space over here, there is a lot of fat and there is a reflection which is much more medially. So we need to mention that, and we see the parametrial extension coming and stopping to that reflection. Now there is no true peritoneal reflection over here at this site surgically. So when we see the vessels all going up to that point of like a plane like this, we say this is close to the lateral pelvic wall involvement, and it will need a clinico-radiological and a surgical decision for its proximity and for radiation planning. Coming to stage 3, when we have the lower third of the vaginal involvement or hydroureter or adenopathy. So in this case, we have involvement going right down up to the anterior, almost the entire anterior vaginal wall is involved. Only a part of the posterior vaginal wall, and beyond that it is uninvolved. So this staging again helps us in better characterization. This is an example where we have the disease which is going up to the bladder. In this case, the bladder was not involved, but this is what I mean by saying that although the distance may be more than 4 millimeters from the vessel, from the external iliac, the disease all seems to be stopping at an imaginary plane, and this would be this may be considered as disease reaching close to the lateral parametrial or the lateral pelvic wall. So this patient, when we go one section higher, we see that there is hydroureter over here and perhaps some dilatation on this side also. So this will be bilateral hydroureter involved by the parametrial infiltration. Coming further superiorly, this is how the ureter is dilated, and we see the disease definitely going up to the lateral pelvic wall in this case. This is the sagittal section in which we see the ureter very nicely dilated and distended, and it stops abruptly where this is all parametrial disease, which is engulfing and encasing the ureter. This is the ureter in the mid-sagittal plane, and this is the ureter on the opposite side, which is again engulfed by the parametrial disease. This is an example of how on the CT scan also sometimes advanced cases we don't need an MRI. So we have a cervical disease seen over here. It has a parametrial extension and there is bilateral hydroureter. A CT scan is very good for this also, and we do not need to investigate further. This patient here has a node over here along the distal external iliac side, and this node definitely looks metastatic, and hence it would be then going to be called as a stage 3C. Stage 4 is when we have bowel or bladder wall involvement. So there is something called as Bullish Edema, which we need to understand. When we have a cervical disease here, this one is involving the posterior and the anterior lip. And this is a bladder and the posterior wall. This is a little more brighter than the tumor. And we can see a continuity of the serosal margin over here. There is a black line between these two structures. So this may not be a direct infiltration of the tumor, but that is more because of the edematous and the vascularity around, which causes edematous change in the posterior bladder wall. It is important to identify that to differentiate from true for better staging. This is an example where there is frank intravesical, intraluminal bladder involvement. Stage 4B is metastatic disease, where we may need to, even a CT is good, and an MRI, incidentally, if you were not expecting a distant disease and the MRI is done for particular symptoms, like say the patient says, I have a lot of backache, and that's when we do an MRI. Otherwise, it is not recommended to do an MRI for hunting for metastasis. But if you happen to have an MRI, so this is how the structures are seen. There is a change in the signal intensity in the vertebral body, which enhances avidly. And this is the anaxial section, and there is intradural extramedullary extension of the disease also. And so this is metastasis. Now, incidentally, on the MRI also, we are seeing definite lung metastasis over here. So if we do see things other than what we are focusing on, it is good to mention that in our reports. So this is another example of lymph nodes, which are seen along with this metastatic disease, which is seen here. Coming to adenopathy, so we said there are regional nodes and there are extra-regional nodes. So the regional nodes for a CA service will be perivisceral. It may not be possible to differentiate for a perivisceral, like a parametrial tumor deposit versus a perivisceral node. But yes, if we see something enhancing, something suspicious there, we need to talk about it. The internal, external iliac and the common iliac nodes are all regional. Para-aortic and inguinal nodes are non-regional. This is important because the staging changes. When you have para-aortic nodes in a cervical disease, it is non-regional. Whereas for endometrial, it continues to stay as a regional nodal spread. So the disease staging matters. Short axis dimension and morphology is important. So again, over here, by literature, it does matter to say whether the short axis dimension is 8, 10, and 12 millimeters for the abdominal, for the pelvic, and for the inguinal lymph nodes. However, that is not something that we rely on. So statistically, we may be correct, but that is a very good way also to miss out on a lot of other smaller nodes which are suspicious. So more than the dimension, what needs to be looked into is the morphology of the node. Now, by morphology of the node, it would be that if the tumor is similar to the node in terms of its behavior, then let us presume that, okay, it is likely to be a metastatic node. So they have the same grayness, they have the same diffusion does not help much in lymph nodes. So that is something always to remember. And if they have irregular margins, if there is, even if they are like 5 millimeters, but there is no hilum and they're nice round nodes, then they may be considered as suspicious. Then nodal metastasis, they do correlate with the presence of parametrial invasion by the primary tumor. So very often when we see a nicely confined disease, we do need to think 10 times before analyzing the node and calling it suspicious or not. And a sentinel node would be the external iliac and the occipital regions, as well as a parametrium. So the implication is that at any stage lesser than 3B, we must look out for nodes because that will upstage the disease. So about the Fibo recommendations, earlier recommendations did not really incorporate cross-sectional imaging, but now with the new updates, it has been recommended. And like, so for example, I mean, if we have this upper para-aortic node or this operator node, sometimes a lot of these findings may have been missed. So what I would say is that with such an extensive disease, this CA cervix going right up to the lateral parametrial wall and such an extensive amount of adenopathy also. But what I want to show is that this patient did not have any hydronephrosis or hydroureter. So meaning to say that just ruling out a presence of a hydronephrosis or hydroureter on an ultrasound does not mean that you're dealing with a particular stage of disease. And this has been understood well over the last few years. And after the recent updates of Fibo, which now incorporates cross-sectional imaging, it seems to be far more prudent with the expected imaging findings. So this is another example where, you know, there is this lateral parametrial stripe of involvement. This is a stripe of tissue which is going. This is definitely a stage 2B, but there is going to be no hydronephrosis with this disease, and there was no hydronephrosis. So this is where a cross-sectional imaging scores over the traditional ways of classifying and the need of imaging. So the impact of imaging on staging, so staging of cervical cancer when based on clinical Fibo compared with surgical staging would be erroneous in up to 32%, with 1B and up to 65% with stage 3. With cross-sectional we score over is the endocervical tumor size, extent of parametrial infiltration, pelvic wall invasion, and the presence of lymph nodes. Definitely we have a huge role to play in planning radiation. So for example, we have, this is a sagittal section. These are brachy rods, which are instilled and the bladder is collapsed, but there is a Foley's bulb seen in the bladder. This is the large black area seen here. This is nodular growth of the cervix and the vagina over here. And this is a rod in the center. This is the sigmoid and the rectum. In the axial section, we see the brachy rod and this entire bulk of soft tissue is cervical disease. This is CT-based planning where we have the rods placed on either side. And this is, there is gradation of radiation given. So when we want to exactly estimate the extent of parametrial infiltration and have graded radiation on brachytherapy, an MRI scores over a CT-based planning. However, CT is widely acclaimed and is a good modality for planning radiation. This is assessment of radiation post-RT response, which is given for curative intent. So there was this very small volume disease over here involving the cervix. And this is the sagittal section. On the coronal section, there was minimal parametrial infiltration over here on the right, which is why she underwent radiation as a definitive curative intent. And the post-therapy response shows the entire grade tumor has come down as just black scarring of the cervix. This is called as cicatrization. And the response is very well seen on imaging. This is the axial section showing no viable disease. These patients need to be kept on clinical and imaging surveillance. This is a response in a recurrent disease where the patient had undergone hysterectomy and then she got recurrence of the vaginal stump. And there is a large volume disease seen here, very badly infiltrating the wall of the sigmoid. Posteriorly and the bladder also anteriorly, we see the bladder involvement right from your posterior bladder wall is thickened and infiltrated with an intraluminal extension. And this is the response post-radiation where there is a significant and a remarkable response. Even the bladder wall integrity and the serosal wall integrity seems to have come back. And the tumor is also markedly cicatrized. In the axial section, again, we see that there is no gray tumor seen. It is all black and fibrous. And we would say that there is a very good response and we would keep the patient on surveillance. This is post-RT response in large volume disease with residual disease. So this was the cervical disease, which I showed, and the adenopathy. And then post-radiation, there is a reduction in the extent of hematometra also, and the adenopathy has also significantly gone down. This is example of assessment based on MR spectroscopy. So when we do a spectroscopy on an MRI, it is a way to measure the concentration of the metabolites which are present in a soft tissue. So choline is a marker of cell growth. So when there is an elevated choline, it tells us that there is a high amount of cellular density. So this is a choline peak usually seen around 3.03. So this is a high choline peak seen here, and post response when the MR spectroscopy was repeated at the same level, we do not see any peak over here. So this is the basal peak and this is the elevated choline peak. So this tells us that, okay, the viable cellularity has gone. Do we do an MR spectroscopy in all patients? We don't. One, because, and is it standardized? It is not, because it can vary from machine to machine and it is not as well standardized. So like in other sites, it can be, if we are not sure of what's happening, then we could consider doing an MR spectroscopy, but it does not fit to have a place in routine protocol for all patients. Looking at post-RT responses, residual edema. So this patient had a recurrent post-hysterectomy. There was a new growth that was formed in the vaginal wall, posterior vaginal wall involved, and it is growing into the endovaginal cavity. Post-radiation therapy, there was this residual vaginal wall involvement over here and some bulk here. So not sure if there was some component of residual disease. On the sagittal section, we see that yes, there is a little bulkiness seen over here. But on the post-contrast imaging, we see very nice homogeneous enhancement of the serosal margins with hardly any enhancement inside. And this is going to represent a edematous component and not really reflecting the characteristics of disease as such. So this is where by a complete multi-parametric imaging, we can say whether this is going to be disease or this is going to be some edematous changes. Yes, there can be complications and we need to image well for that post-RT also. So for example, there is urine here on the CT scan and that is coming out over here through a fistulous tract and reaching the anterior vaginal wall. So this is a residual fistulous communication with the vaginal wall, and a delayed scan shows good active extravasation of the urinary tract. Not urinary tract, of the fistulous tract, and the contrast is seen to come into the vaginal cavity. So this is very nicely exhibiting the fistulous communication. Some other features which we need to see, like say example, an MRI has done and your patient is constantly complaining of a lot of backache, low backache, but there is no other residual disease. There is nothing explainable. If the patient has had radiation, it may be worthwhile to have a relook at the bones, because like, so for example, there are these dark hypo-intense lines seen in here, over here in the sacrum, and also seen here. These are very classical of stress fractures, because what happens is in post-RT status, there is a weakening of the bones. There is more of fatty marrow replacement in the bones, and these bones are more prone to developing insufficiency fractures, and that may be the cause of the pain. This is a stir sequence or the fat sat sequence where the normal marrow is black, but this is all inflamed edematous marrow seen very well on the coronal sections also. And this was a stress fracture or an insufficiency fracture. Picked up on a routine and small FOV resolution. This is much more crisper. And this is diffusion sequence telling us the functional characteristics of being a high cellular lesion. Role of dynamic post-contrast imaging. So I would say if there is frank parametrial infiltration or definite that apple-like exophytic lesion, which I showed, where there is no parametrial infiltration, I don't think we should be giving contrast to the patient. We can save the time and the cost out there, and it has no added value. However, when we are not sure whether there is parametrial infiltration or not, there the dynamic post-contrast imaging would really help. So for example, over here, I know that this is a tumor which is definitely not having any parametrial infiltration, but on the axial sections over here, we are not sure of this interface. The vaginal jelly beautifully elucidates that there is nothing involving here, but say 12 o'clock to 2 o'clock axis, I'm not sure what's happening. This is where dynamic post-contrast imaging steps in, and I'll show you how. So in the early arterial phase, we see the arteries enhancing. So what we were seeing over here was arteries. And then as we go on sequentially to the later phases, the whole venous plexus is involving over here. And the tumor is enhancing differently. So after seeing the addition of the vessels in the arterial and the venous phase, we don't see tumor going there. So this was a false presumption of minimal parametal infiltration, which is actually because of a vascular leash of a leash of vessels staying out there, which is giving us that differentiation. So subtle changes when we want to see, they can be helped well by using additional sequences. This is post-therapy assessment for recurrent disease. So like this patient underwent surgery and then there was recurrence. So this is a very frank recurrence. We are not, there is no doubt about the diagnosis in such a case. Coming to CT. So in advanced disease, so on vaginal examination, if you feel your patient has advanced disease by parametal infiltration, then directly ask the patient to go ahead for a CT scan, because here what matters is to rule out metastasis and to look for lymph nodes. That will determine the staging. We don't believe in wasting time, money, and efforts for such a patient to undergo an MRI. Unless the planning for radiation is going to be based on MRI, there is no role of an MRI in such a situation. CT is always going to be a better modality to evaluate the chest, abdomen, and pelvis in one go for overall staging and for RT planning as well. It is a more commonly available, widely used modality. And it is not the best modality for soft tissue characterization, endophytic diseases, parametal infiltration, but it is also very good for response assessment. So once you have the diagnosis and if the patient is kept on chemotherapy, yes, we can see. For MRI also, for radiation also, a very good response is seen on CT, but if we are worried to look for small functional parameters that after the size has gone down, is there still a possibility of the gone down size having some residual component? That is better seen on an MR. So if the purpose of response assessment is chemotherapy, then I would recommend a CT scan. However, if it is for a small possible residual disease on an post-RT, then an MR scores better. This is an example of a post-chemo response assessment where we have obvious disease over here and adenopathy, which all has gone down. Even over here, there is response, that is partial response. Now, role of PET CT. So yes, we beautifully see it all lights up. You see the image and it is like enlightened. There is a large bone met, there is a large lung met, and there is a nodal met here. But the point is, these are all also seen on a CT scan. Okay, so everything is seen here. So the point again would be that yes, a PET CT is good in advanced stages, but CT scan often does a job, and you may reserve PET CT for a certain set of patients where you're not sure whether you want to characterize the lesions better. So a good CCT is going to show you most findings that will be picked up on a PET. If at all a PET is being done for any reason, it is good to combine the PET with IV contrast CT. So it is a PET CECT, so that added information is given from both sides. So if there is resource constraint, I think a CT is very good. If somebody is using a PET, please use it with an IV contrast. So this is an imaging checklist, which you can always discuss with your radiologist to give you the answers that you want as a clinician for your further management. Some softwares can be used for like hypoxic imaging, where this is perfusion-related acute hypoxia, and that may help you in planning your radiation. I'll move on to carcinoma endometrium. So what I will show you in where I'm not useful is to tell you the histology of the disease. So it is good to say, oh, this turned out to be like this, but this is exactly, so this is an endometrioid carcinoma, and I will begin with the histopathology because the entire uterus over here is filled with a large mass. I cannot differentiate any soft tissue structures here. And when I go ahead, so this is an MRI done for the same, and this is the T1 weighted sequence, and this is T2 weighted sequence. dark on T1, bright on T2 uniformly. All I can say is that that this is a large mass filling up the entire uterine body and markedly diffusion restricted. This is likely to represent a malignancy. And that was a endometrioid carcinoma. Coming to the second one, which is a clear cell carcinoma, very similar signal intensity. I'm not seeing any difference in the structure. So am I of any help to give you a histological diagnosis? No, that is not my forte, and we fail terribly out there. So we are not good at giving the histopathology. Where do we step in? It matters for you to manage the patient. And that is where the extent of staging becomes important. So the reason for doing an imaging would be for the stage, the depth of myometrial invasion, lymphovascular invasion. We cannot comment on imaging again. But yes, if there are obvious nodal mets, and that may be a predictor of possible advanced disease. And the histologic grade is again. So these three are not in our hands, but the first two are in our hands to help you with further management. We will not get into the TNM staging and the guidelines because they have been covered. So let us look at the images directly. So this is an early stage 1A disease where we have disease which is into the endometrial cavity. We have the posterior myometrium and the anterior myometrial wall. And this is the endometrial tumor. This is very well restricted on diffusion and it is dark on ADC. So when I have this combination, I know that I'm likely to be dealing with a tumor rather than just hyperplasia or a polyp. Now, looking at this, I see the posterior bulk is maintained. This is less than 50% of the tumor. Anteriorly, I'm not sure whether it is more than or less than 50% of the tumor. So that's when post-contrast imaging helps. So when we see the post-contrast imaging, the myometrium is enhancing avidly compared to this, and definitely the thickness is less than 50% involved. So that would be a stage early disease with less than half myometrial invasion. This patient over here, there is a large endometrial growth and the myometrium is barely seen as a stripe of tissue. So when we look at this over here in the sagittal section of the post-contrast, it is looking more like a compressed myometrium rather than an invaded myometrium. So is there myometrial invasion? Well, probably or probably not. So that is why the recent classification is much more favorable for accurate staging, because earlier there was one partition which says, is there myometrial invasion or not? So we are not very good at that. But is it more than 50% involved or less than 50% involved? Yes, we are definitely better at that. So with the removal of that early stage 1A1, our diagnostic accuracy now improves. So I would tell you that there is no myometrial invasion along all these sites, but there is this one focal area where there is breach of continuity and it might be involved. Even if it is involved, it is right up till here, which is less than 50%. So it is important to comment on a compressed myometrium versus an infiltrated myometrium. And once it is infiltrated, how much is the percentage of infiltration? As it less than half or more than half? So now look at the dynamic staging. So do you see this line over here? So this is the outer margin of the uterine surface, and this is the inner myometrial lining. This structure is the endometrium. Please pardon these few artifacts seen curvilinearly. I wanted to focus on this line. So in the earliest phase of a dynamic post-contrast imaging, this is called as the endometrial halo. So the first thing to come up, so if I want to see the continuity, you can follow the arrow. There is breach of this endometrial halo at this point here. And again, the endometrial halo continues here. There is a breach here, and then it again continues over here, which tells me that either there is some involvement of the myometrium at the places where there is a breach, or it says that there are adenomyotic changes which are going to limit my further delineation of myometrial invasion. So presence of adenomyosis is a limitation for assessment of extent of myometrial invasion in endometrial tumors. Let us look at the delayed images. So delayed images, the myometrium is beautifully enhanced, and I would say that it is probably not involved. And this breach here, at the most less than 50% involved. This is definitely early stage. So having my entire baggage of sequences and putting them up like a jigsaw puzzle, eventually I would say this is definitely less than 50% involved. Now, in this case over here, we have the endometrium distended and the myometrium is very shaggy over here. Look at the parasagittal. The tumor seems to be going and creeping into the myometrium at multiple places. This is in more than 50% involvement, stage 1B. But if I look at the endocervix, so I mean, there is extension into the endocervical canal, but also into the stroma, which would make it a stage 2 disease. So here we have encroachment or creeping into the endocervical region. So this would be a stage 2 disease. So again, coming to stage 3, where we have vacillation. So over and all, if I am to report the CT scan, I would say the uterus is enlarged with a vacillated appearance. A mimicker of this is multiple fibroids. So I will not be able to differentiate this. If I start calling every such image as a case of uterine malignancy with serosal involvement, I will be wrong a lot of times because it could be fibroids. But if you have a case confirmed on your brushing cytology or a DNC that, okay, this is a case of endometrial malignancy, and then we see this, okay, then this is likely to have a extraserosal spread. In such a case, if a CT scan has been done for some reason and there is no metastasis, there is no metastatic adenopathy or something, if it is only a confined disease with a histopath proof of endometrial finding, I would suggest in such a case, please go ahead with an MRI and rule out the presence of fibroids with a smaller volume disease, because that could change your management significantly. So such as appearance on a CT scan with no lymph nodes and no metastasis, it would be worthwhile to do an extra imaging with an MRI and look at the tumor better. So lymph nodal mets, again, we can have pelvic nodes, nodal mets are more common than para-aortic nodes. Isolated para-aortic nodes may occur, which has to be remembered. And node positive endometrial cancer is more common in tumor, higher stage and higher grade. So this is a tumor with a higher grade where we have metastatic adenopathy on both sides. This is also a large node here and here. So CT helps better in advanced diseases. And role of MRI in staging would be more for the loco-regional extent of myometrial invasion. And the pitfalls where we fail in our accuracy would be a very large tumor, which is compressing the myometrium as I showed. Corneal extension, we have to pay good attention to see whether it's extension into the cornea and the distance from the cornea. Coexisting abnormalities such as congenital anomalies and adenomyosis and a poor tumor myometrial interface do cause to a poorer diagnostic accuracy from our side. The role of MRI is very well established by multiple guidelines, and these are discussed, and I would not want to get into those for now. But to summarize, loco-regionally, I do understand our socio-economic status, and even in our country, I'm not saying that we go and do an MRI for all patients, but if we have a chance, if we have in a resource available situation, use an MRI for loco-regional staging only, and we reserve and CT scan and ultrasound is helpful in all other situations otherwise. So like, for example, this case over here, so confined disease, wherever surgery is going to be useful and beneficial, I think an MRI is good for telling you how exactly where you stand for triaging your management. So there is this little soft tissue seen here and in the axial section also over here. It is very beautiful delineated on the other section. So that means this is a polypoidal-like tumor, and but the restriction is very high on diffusion. So this may be a polypoidal endometrial malignancy. And then on the post-contrast, we see that structure to represent a leash of vessels which is feeding the disease. And this was a polypoidal-like endometrial growth. Another example where this tumor is completely replacing and reaching out up to the myometrium, I would say, on the T2 weighted imaging. And I don't think there is a doubt on this. However, on the post-contrast, there is a very good bulk of myometrium around also. And here I see the tumor going, so if this is an uninvolved myometrium, this is about half the involvement and maybe just a little more than half here. So this patient did have on final hysterectomy specimen, involvement was seen at places which is less than 50%, and at overall at some places up to half the myometrium. So this is just to show that a good analysis, if we would have reported our patient only on this tumor, there was definitely tumor reaching to the serosa. But when we combine it with the post-contrast imaging, it does change our diagnosis, and which is why it is important to scan well and use all the sequences. So an endometrium, as I said, in cervix, we would reserve the post-contrast for a particular sect of patients where we are not sure of parametrial infiltration. But in an MRI, when we're doing for endometrial cancers, all patients must undergo post-contrast imaging unless you're doing an MRI for any other non-metastatic patient for other reasons. Otherwise, contrast is not needed. This is presentation of a patient with metastasis. So again, this is a stage 4, and this was quite like a tuberculoma or tubercular abscess was also differential, but this was a metastasis from a CA endometrium. Coming to carcinoma ovary, so usually a patient would come to you with an ultrasound. Now, ultrasound, so this would be like a ORADS1 case. This is a nice normal ovary with multiple follicles. We are all happy with it, so there's nothing to worry. So what is the role of ultrasound? Ultrasound is very good in characterizing ovarian masses. And unfortunately, ovarian masses do reach the medical fraternity at a point of time when it is not very early, and that is an unfortunate part of it. So, but if you start looking at the management and triaging of such patients, if you have a patient who's come with ascites and or a very large mass, I don't see any role of an MRI. A good ultrasound, if it can pick up metastatic sites, then that is going to be, that is enough for you to then go ahead with a biopsy accordingly of a peripheral site, like, or biopsy of the omental caking or something seen, and going ahead with the management. Here, if we do a CT scan, it can serve as a baseline for your future investigations, but there is no role of an MRI in this scenario. MRI in ovarian cases would be used for certain not sure of the diagnosis, the indeterminate category or the intermediate category, and that's where we use. So ultrasound is often the first investigation. There is something called as an RMI score or the Vimy score, which tells that, okay, with this particular score, you refer to a specialist, but this is there in literature. We also try to use for some patients, but we do find it erroneous in a lot of situations. So this is something which is good to know and can be discussed with your clinician, but we don't really use it. An MRI can be used for complex masses with thick wall or enhancing septae, papillary projections to see solid areas with necrosis to confirm enhancement in an indeterminate area, bilateral lesions, ascites which is seen anterior to the uterus, but you're not sure of any peritoneal nodules or implants or something, or any other ancillary findings such as omental deposits, ascites, hydronephrosis, invasion of pelvic walls, and adenopathy. But these I would reserve a CT scan, which is going to be far superior for overall staging than an MRI. Coming to multiparametric MR again, so we have like diffusion, perfusion being done for MRIs. There are types of curves which I will show you. So there is something called as an adnex MR scoring system, which I will show you with an example. And the types of curve, they represent the probability of malignancy or benignity. So for example, this patient here, this is a T2 weighted imaging, uterus, and there is a left adnexal mass. This is a T1 weighted imaging where this is bright. So something bright on T1 tells me it's either fat or protein or hemorrhage. So maybe this is not really a malignant complex mass that was seen on ultrasound. And on the post-contrast dynamic, I see this as a first sequence. So this is not enhancement. This is the same bright area which is seen on the T1 and should not be confused as enhancement, which is why it becomes important if a patient comes to you with two sequences and then you start trying to interpret from those two sequences, we can be wrong. I can also be wrong. So we do need the whole set of images to give a more sensible diagnosis than to just give a bird eye view of, oh, this is what I feel. So if a review has to be done, it needs to be done well in an appropriate manner, or rather repeat an imaging in your center so that you can have the soft copy if a CD is not available, and analyze each and everything. As I said, fitting things in a jigsaw puzzle is important. One piece missing can lead a change to the imaging, all right? So this is diffusion. There was nothing much on diffusion, restriction and everything. And this is the post-contrast image again, nothing here on the perfusion map also. So dynamic curve is plotted for the solid tissue, and we so there is a reference. We look at the reference between the myometrium and the adnexal soft tissue, and there is a very slow progressive rise. So this is not likely to represent a malignancy. This patient can be kept on surveillance, and she was normal on surveillance. There was no significant change. On the other hand, so this is just to show I do not need to plot a curve. If I have the uterus here and a left adnexal mass, this is enhancing myometrium and this is enhancing solid component, I know this is malignancy. But just for a teaching module, if we start plotting curves here with a reference over here, so we see the reference and we see the brightness in the myometrium. The tumor is also equally brightly enhancing, and there is a rapid growth and a persistent, there is no washout, there's a persistent retention of contrast. This is a malignant type of a curve. So this is what the adnex scoring system is, that we determine the probability of malignancy based on the type of perfusion and curves. Benefit of CT over MRI in staging, as I would say, these are calcific areas. These will not be seen well on the imaging. So there are calcific areas here. Now, when I look at a large calcific area, it will be picked up on ultrasound. Maybe it may be picked up on MRI also, because it will have some soft tissue component. But these tiny calcific nodules, which actually can represent metastatic deposits in the peritoneum from your primary, that can very well be missed out. So for such cases, when you are presuming or when your ultrasound report says that there is possibility of calcification within, we have to go ahead with a CT scan and not an MRI. But if that calcification is likely to be with a fatty component and they're suspecting a dermoid or something, you may think of an MRI or a CT. But once again, CT also shows fat very well like an MRI. So we can still go ahead with the choice of a CT scan. So role of cross-sectional imaging, as I would say, either for CT or an MRI, would be characterization, staging, assessment of the peritoneal cancer index, predicting inoperability, optimal cytoreductive surgery, and post-therapeutic surveillance. So for characterizing, this is not an indication, I would say, for an MRI, but this patient had nothing else. So there was this large adnexal mass, and on the post-contrast MRI, this is the corneal section, there is enhancement of the solid component. So no brainer on the imaging. Anybody sees, you can say that, okay, this is a suspicious ovarian mass. So characterization helps. Why was an MRI done in this patient? Because this patient had isolated ovarian masses. There was no ascites, there was nothing else. It was a disease which was likely to represent only the site of the ovaries. And there was some differential of a hemorrhagic fishnet appearance, clot or something, which was why an MRI was done for characterizing the lesion, because that would change the management and the biopsy assessment for that patient. Staging of diseases. So over here we have the uterus. There is a right adnexal mass, and this is the left ovary. So the left and the right. So right, definitely we have a solid internal component, which is showing us avid enhancement over here. And this is going to be disease confined to the ovaries. There was intense uptake on the PET CT. The PET CT patient had got from outside, but if everything else is normal, no other reason to do a PET CT also. This is a operable disease with no local further local regional extension. An example of another patient where we had, this patient had a midline mass and a solid component. This was also definitely suspicious, we would say, based on the ultrasound with having a solid component more than 7 millimeters. She underwent an MRI, and there was, so this is just how to show how the disease looks on an MR. And again, she had no other fluid or no other metastatic site. So for confirmation of the same, an MRI was done. So there is a fluid level over here. This is representing hemorrhage associated with the tumor, but it is confined to the ovary. So let me show you, this is how the post-contrast assessment showed enhancement of these neural nodules, and we have bilateral adnexal masses. This same patient, however, when we saw the corneal and the sagittal sections, So there were these certain areas where very nicely I can see a breach. So this is the ovarian disease over here. And there seems to be a kind of a breach across this capsule, and we would call this as an extraserosal breach. And that would be changing the staging of the patient. So for example, this is the one where we had fluid level. And in the other side over here, taking the sagittal section, we nicely see the margin, the serosal surface and an extraserosal breach. This would upstage the disease, and this was very beautifully seen on the MR. This is the post-contrast assessment. This is an example of a peritoneal deposit, so which may have otherwise been missed. So CT scan is not going to show this well. There was a lot of ascites here, and there is a small little implant seen here, which can be seen separately from this structure. So this had intense restriction on diffusion. So this is definitely a malignant deposit. And this is not even the kind of diffusion restriction is such that this wouldn't have even a differential of a small fibroid in the broad ligament. Another example where this is the posterior peritoneal reflection, the bladder, the uterus, and the posterior peritoneal reflection in the pouch of Douglas. This is the fluid here and a peritoneal deposit here. So picking this up with no other disease elsewhere is going to definitely upstage your disease. So it is also, this is enhancing on the posterior image, and the axial section showing enhancement. So this nodular deposit is definitely suspicious, and this will upstage the disease. So loco-regionally, when you're sitting on, let's say like a weighing scale of which therapy to use, an MRI is going to help you in those patients. This is a large volume disease and large deposit in the pelvic pouch of Douglas. So we don't need an MRI for this. Even an ultrasound or a CT would have helped. There is a large metastatic node over here in the lateral sacral space. And this is metastatic. So by large, I would say this measurement would actually be about 5 millimeters, but 5 millimeter node, it is not fitting the size criteria. But if you have this node, which is like the parent tumor, so I would say nodes are the babies of the mother. Okay, so if they behave like the mothers or the tumors, we must consider them as suspicious. This is a para-aortic node again. So the staging changes with these findings. This is an example of picking up peritoneal deposits. Please mark my word, MRI is not an imaging modality of choice for looking at these findings. Given the number of artifacts, it is nice to show in a presentation that, yes, see, this is how the peritoneal deposit is seen. When we start looking at patients, the bowel loops can mimic these deposits. Sometimes there are artifacts from peristalsis which can hamper your appearances. So if we do suspect a higher volume disease, please go ahead with an MRI. However, if an MRI shows a local disease, we do need to hunt to look at an abdominal screening sequence to try to pick up these findings. These are much more larger deposits in the peritoneal space, and these are very easily picked up. Diffusion restriction, surface deposit over the liver. These are again lymph nodes which are picked up on the RP node, but you see the resolution. Look at this node and see how beautifully the node is seen on a CT. So a radiologist has to struggle to not miss these findings, which are so very well easily seen on a CT scan. So this is how CT can help in extensive advanced disease with nodal disease and pelvic nodes, para-aortic nodes, hydronephrosis. All the imaging information is given very well on a CT. This will also be given well on an ultrasound. This is example of a stage 4 disease where there are mets all over. Coming to estimation of peritoneal cancer index, so we have our longest 4 criteria which can tell us the deposits which I've shown you. Predicting optimal cytoreductive surgery again, so I would not dwell into the detail, but yes, we can give the dimensions and indicate a CCR response of 0 to 3. Post-therapeutic surveillance, so for example, so again, post-therapeutic surveillance, for one point I would say here is always and always have the CA-125 levels in place. The first thing is to confirm which tumor marker is elevated in this particular case of ovarian tumor, and to follow it up, because very often the tumor marker surrogate and the imaging surrogate go very well in hand. And to reserve your chemotherapy cycles for ovarian cancers, to reserve the second line, the third line, sometimes picking up a recurrence on CT is not enough or valid enough to intervene with a surgery or starting the second line of chemotherapy. So this is where my job ends by saying that, okay, I'm seeing a new finding, I'm seeing a progression, but whether that translates into changing management, into re-intervening by a surgery at that point of time, or to start a new cycle of chemotherapy, you all are much better at that decision, and I would not be able to help in that decision. However, when the patient starts having bleeding for rectum, or we are seeing the mural infiltration of rectal wall going into the luminal mucosa. So these are certain findings based on the kind of recurrence. We can decide whether we want to do an MRI or a CT for follow-up of such patients to look at the point of interjection of changing therapy. So this is an example of how an MRI helps to characterize, which I have shown. All right, this is enhancement of the wall, and so this was thought of a hemorrhagic clot, but confirming enhancement in a solid component tells that this is a disease, and we have to intervene surgically if there is no other metastatic spread. Post-operative patient had a scar which earlier was thought to be inflammatory, but there is definite clinically it was just redness, and this was seen very well on imaging, and this was considered to be recurrence at the scar site. Post-chemo response assessment, there's a whole muck of tissue here, and on follow-up it all has gone down. So again, it helps. There is an ACR appropriateness criteria where it says ultrasound per abdomen or transvaginal is usually appropriate for a possible benign mass. However, for an indeterminate mass in the pre or post-menopausal setup, an MRI pelvis becomes an imaging modality which becomes now usually appropriate. To look at highly suspicious adnexal mass, CT or an MRI can be usually appropriate. But as I said, I would still further triage. If definitely metastatic, please go ahead with a CT scan, and MRI to be reserved for management changing criteria. So ORADS is now new on the block, and you will have radiologists starting to use ORADS in their reporting systems. So just to give a quick gist on what the ORADS is, one is a normal ovary as I showed in the ultrasound image. Two is, I'm quite certain this is benign, and there are management recommendations of how often the patient needs to be on follow-up, whether the patient needs to go to a special ultrasound physician or for an MRI. Category 3, 4, and 5 now start having some low, intermediate, and higher risk of malignancy. And there are various features which tell whether you go to an ultrasound specialist or an MRI. And at an interjection of 4, the patient would rather be referred to a gynaecologist, and in 5, definitely a gynaecologist needs to be stepped in. So 4 and 5, gynecologist perhaps needs to work in collaboration with the gynaecologist because it needs special dedicated management. So I would just show you some cases. So for example, this, so just to show, this is a large abdominal mass and very, very variegated on appearance, many echogenic areas, and not sure of what it was. CT scan was done. And so these were like some not so enhancing areas and the uterine part. And so it was not very sure, but this did turn out to be a fibroid. And this impingement of the vessel coursing through was how the fibroid folded upon the broad ligament, and it went on occupying the entire abdominal pelvic cavity. So meaning to say, everything that is multi-septate on an ultrasound does not always turn out to be a uterine mass, and you may need soft tissue characterization. And MRI would definitely have helped in this clinical context by ruling out enhancement, avid enough, but the patient underwent surgery after the CT scan. And this is another patient where not a very different appearance, and this is an ovarian tumor. So sometimes imaging does not help, and yes, you'll always rule. So that clinical correlation with tumor markers and imaging parameters are essential, and they form a key to the holistic diagnosis of the patient. Role of CT, so as we said, calcifications and fat. So this is a teratomatous tumor. So this is very beautifully seen on CT. Or an MRI may be done. We would prefer a CT. And this is to show that not everything which looks like a teratoma is always benign. And this patient had splenic deposits. So this was an immature teratoma and not a mature teratoma. So CT scan is the most ideal way to diagnose these, because even on ultrasound, we may miss these findings when they're small and subtle. So for example, here this one deposit is seen with calcification, but if there is a lot amount of fat, we may not see. Because of soft tissue, it was seen on the ultrasound, and this is how the deposit is seen on the liver surface. But these tiny calcific deposits also, if we did not have the liver, this deposit here on the liver surface, and we only had these calcific deposits in the omentum, they may have been missed out. Like in an obese patient, when the organs are seen, and not everybody always places the omentum covering the entire skin of the abdomen. So these are areas where a CT will still score over an ultrasound. And this patient had a large calcific mass in the pelvis. This was a malignant disease. Here somebody thought of a staghorn calculus in the bladder, in the kidney, but there is extensive deposit of another immature teratoma with extensive calcification. This is an example of like, an ORADS 2 kind of a structure where there is diffuse posterior shadowing. However, the patient was not willing to stay on surveillance and she was wanting to be very certain of the diagnosis. So she underwent an MRI. And so we see there is this fat component over here, which is suppressed on stir. So we know this is a clear cut fat component, and this is a hairball, and this is going to be a benign lesion. This is another case of ORADS 2, where this is a simple cyst done on an MR for some other reason. Smooth, homogeneous peripheral enhancement, nothing to do, the patient needs to be on surveillance. And that is how the ORADS helps in managing or triaging the patients. This is an example of an ORADS 3, where this is a multilocular cyst, and it has few septae, but there was very minimal vascularity, maybe for score 2, but definitely not intensely vascular. And this did turn out to be a CT scan was done, and this is all non-enhancing, high-density structure any which ways, and nothing avidly enhancing. She underwent an MRI because she was young, fertility preserving required, and CT was not very good in ruling out enhancement. So the best modality to tell you where there is subtle enhancement is to use fat saturated dynamic post-contrast imaging. So we have this disease here, sorry. And on T1, there is a lot of hemorrhage or mucin which is marked. And this was just a leash of vasculature when we traced every step of the scan. And this was essentially not an avidly enhancing tumor, and that was a cystoadenofibroma. So this is how, again, ORADS can help you in triaging which lesions need concern or not. This is a multilocular cyst, which was large, more than 10 centimeters. So it becomes an ORADS 4. And this same patient, I mean, it seemed to be confined, but does it become an ORADS 5 on the CT scan? There was a good amount of ascites also, which obviously would have been seen on ultrasound also. But meaning to say, once you have ascites with this kind of a mass, it becomes an ORADS 5. This was a case of a dysgerminoma. This is a classical case of ORADS 5, where you expect solid masses in this multilocular mass, and there is intense solid enhancement of all these septae. This is another example of an ORADS 5, where these look like multiple complex masses with a lot of solid component within. And this is an MRI of a complex ORADS 5 mass. This would be solid masses in an ovary, which represent an ORADS 5. And this was Kuchenberg's case of Kuchenberg's tumor, bilateral ovarian metastasis. My take-home message for you would be that ultrasound usually is the first modality of investigation. It is pertinent to justify the use of cross-sectional imaging judiciously for a CT versus MRI for the findings as I described under each heading. For cervix, please remember to use a pervaginal sterile jelly because it does change the staging, and reserve the contrast only for cases where it matters. For endometrium, if an MRI is performed, dynamic post-contrast imaging is useful. In ovary, ORADS assessment may be of value in triaging what to do when, and a tumor marker correlation is always helpful. Thank you so much.
Thank you very much, Dr. Parul Govesh. It's really excellent, not excellent, it's amazing. And your presentation with a non-stop presentation, more than 1 hour. And we are very happy and we are very grateful that the right person who you are chosen by our Supriya Chopra ma'am. We are very much grateful to Dr. Supriya Chopra ma'am. And we are happy that our topic choice is probably it is the right time and time demanding. For that reason, even after Ramadan, more than 120 participants have joined in this session. And probably due to the prayer and Tarabi prayer, somebody have left. But first, our fellow Dr. Sushmita Bordon, she has presented all the guidelines and what should be done in case of all the gynecological malignancy. And not only that, she also showed that in a low resource setting, only the advanced imaging, ultrasound can how it can help us. And we are also happy that the Dr. Omita Maheshwari Madam and Dr. Bhagyalakshmi Nayak, both of them were with us in this presentation. Now I would like to Dr. Palok, if you have in time and if you don't feel the exhaustion, then there are some questions in chat box I would like to ask you.
Sure, please. Yeah. So at the outset, I would also like to thank the entire Gynae Oncology DMG team at my institute, because what we are today is what is shaped by them. For they want certain things and they say we don't want this, and every feedback from them makes us what we are. So I would really thank our patients and my entire Gynae Onco team at the hospital. Thank you.
Thank you, Dr. Palok. And because you don't think that we do. In one day you have covered everything, but in future, we are so happy that in future we'd like to invite you more.
Do you have questions?
Yes, there are questions in the chat box. I would like to ask you the questions.
Yeah, please tell me.
The questions that is MRI or CT scan are performed with contrast unless contraindicated, but contrast is not required for screening chest CT. Why?
For screening chest CT, you only want to look for lung nodules in the lungs. So the lungs look black on CT scan and the metastases are going to look white on the CT scan. All right. So you don't need to see post-contrast enhancement in those in that setting. Hence, we do not need to give contrast for screening chest CT. But I would say when you, if your patient is going to be going for a screening chest CT, a personal recommendation would be to give contrast and do an entire staging chest CT, abdomen, pelvis to know exactly how much is the burden of disease rather than only doing a chest CT screening.
Okay. Another question is lymph node enlargement due to the tuberculosis or malignancies. Which imaging modality is needed to differentiate?
So if you have, so generally this is a comprehensive thing. If we see findings of tuberculosis elsewhere, like if we see primary signs of tuberculosis in the lung parenchyma, there are certain ways that we can see. If it is fibrocavitatory, if there are branching nodules. So if I can say that there are infective changes in the lungs and there are loco-regional lymph nodes, which are necrotic and even if they are enlarged, and there is a CA cervix, which is not a very advanced disease, then we can give the benefit of doubt that it is lung involvement and mediastinal nodes involvement. Together, they do fit in tuberculosis, and we can, it's an early stage cervical disease. So it is more of a discussion with the clinician also. But if it is an advanced stage disease, then sometimes we might need to biopsy and see the other way. PET CT also does not help much because both will show an SUV uptake. So there is no definite answer. So the answer is, if you have pulmonary changes of Frank Cox in an early cervical disease, we can give a benefit of doubt. If we want to confirm, then we will still have to biopsy the node, which is going to change your management, and look at it accordingly. But no chest symptoms, no other signs of TB, and large cervical disease with nodes, we would presume it is malignancy. We don't start biopsying each and every node, but still if there is a dilemma based on that patient, you have to biopsy.
There is another question from Fahana Kalam. Which imaging is more preferable for diagnosis and management of ovarian cancer among CCT or MRI? I think you have already mentioned everything about that. Another question is for patients with suspicious of peritoneal carcinoma metastasis, MRI, CT, which modality it is also, I have to also you have that described. Can CT scan the volume? Can CT scan the quantify the volume of the ascitic fluid?
No, CT scan cannot, because if ascitic fluid is going around everywhere, you cannot really quantify the volume. Even on ultrasound, what we measure is it like in the 4 pockets or something, but in a free flowing, unless it is loculated ascites, any modality can quantify. If it is free flowing ascites, we cannot. It is just subjective, mild, moderate, marked.
In which cases we need Diffusion with MRI?
All cases, I would say. If you're doing an MRI, don't do it without diffusion.
Okay. Which imaging is more preferable for diagnosis of the recurrent CS cervix or a neoplasm? You have already mentioned that the MRI is very important. And another question is, doctor, what are the characteristics of metastatic lung nodule in CT scan?
Lung nodules in CT scan. So if it is cervix, they often are cavitary nodules. So that becomes important because cavitary nodules can be in infective cases also. So we need to look at the overall staging of the entire patient and see if there are mets otherwise, or if there are higher up lymph nodes in the retroperitoneum. We see the imaging and we can make out that, no, this is an aggressive disease. With that, if you have cavitary lung nodules, we would say this is consistent with CS cervix. But in an isolated findings, if there are cavitary lung nodules, we need to rule out infection also. The other nodules for ovary are generally larger. They are more heterogeneously enhancing when we give post-contrast also. And for endometrium also, again, they will be larger, but cervix is more known to have a nodal spread otherwise. I mean, ovary, of course, goes, by the time it will have lung mets, it will also have mets at a lot of other places. So it's an overall characterization that is needed. Only to remember, cervical cancer can have lymph nodes, can have lung nodules, which can be cavitatory, or they cavitate over time.
Thank you. Sometimes cancer patients at their follow-up period, they came with the bone pain, joint pain. Which imaging is preferable them? I think you have mentioned that is the MRI. Which imaging? This is MRI, and it is the with the metastatic protocol, I think. Am I correct?
Yes, if it is a focus, one symptom, one side, we can go ahead with an MRI. And otherwise, if there are multiple pains and joints and everything, then maybe a PET-CT may be more helpful.
In vulvar cancer, if inguinal lymph nodes are not palpable, which imaging in modality is better in that case?
Nothing helps more than the surgical assessment, but otherwise an MRI generally is good for nodes, or even a ultrasound. Even an ultrasound will help you detect inguinal occult nodes with a variable cortical thickness and loss of high lymph. And an FNAC from those inguinal nodes will generally help you in better staging of the patient.
Okay, thank you. Thank you very much. Now I would like to, Professor Dr. Omita Maheshwari, Madam. I think Madam has joined the presentation of our Dr. Sushmita Bordun. I would like to request Madam to comment on Dr. Paluk's presentations. Omita Maheshwari, Madam, please. Is she not here? Oh, probably she left. Yeah. Sarase? Mehdi? Mehdi?
No, I sound nice, bro.
Achi, আমি আছি থাকবো না কেন?
ও আচ্ছা স্যার।
হ্যাঁ?
Sorry, sir.
Thank you, sir. Probably our scientific secretary, Dr. Kamaluddin, she has gone for prayer. This Tarabi prayer already, it is near to end Tarabi prayer. So I would like to request the excellent presentation. And I think all our doctors, our students, all are very much, will be benefited from this presentation. And we will be very happy, and we like to invite you in future for getting this type of presentation. And I think you will be happy to present in this forum, and we will be very grateful. And I again the thanks and will be grateful to Dr. Shukriya Chopra ma'am to select the right person for the right program. Now I request our president, chairman of the 2-day session, Dr. Professor M.A. Heiser, to say something and conclude the session. And I request all the participants, and I thank again that because all you have, even after Ramadan, have joined this program. And another message is to that we'll have a great tumor board session in the 6th May, and that will be in joint collaboration with Med General Hospital, and all are requested to attend at the end of the Eid al-Fitr. Sir, please.
Okay, thank you, Sana. It was excellent papers presented by Dr. Papat. I'm very grateful. I'm very, very grateful to you and your organization. It was a really wonderful paper. I just cannot say anything more than that.
Thank you. Thank you so much.
Thank you for your welcome. Also, I request, I congratulate Dr. Susmita, but she has also started it as far as she could go. But I think each and every participant will be benefited from a lecture, from this lecture of ours. There's only high time, so without any delay, I want to finish it. Okay, Shana, please break up.
Thank you, sir. Thank you very much. Thank you, Doctor. Again, thanks to Dr. Palok, and I request you to send my greetings to Supriya Chopra ma'am and also Amita Mashri ma'am and all the TMS team. Thank you very much.
Yes, definitely. Thank you so much. Those surgical images were by Dr. Amita Maheshwari. The surgery images that I showed in my presentation, they belong to her. Yes, okay. I will surely convey your regards. Thank you so much.
Thank you.
Amit is very much a member of our oncology club. She has taken so many parts here, times in our functions, our webinar. We think she is a part of our oncology club. Hope you will also feel better in future with us. Thank you once again. Okay, bye-bye, everybody.
Thank you, sir. Thank you very much. Maybe please.